So we can start with the second session, and it's a pleasure to invite my colleague Leah before. Oh, sorry, the Professor Michele Miragoli. And Francesco.
So good afternoon, everyone. And thank you, Leah, Dele Valeria, and Francesco for the invitation. It's really a pleasure to start this medical science topic. I'm here to grab a little bit of your time. We are connected so they can hear us abroad, right? Okay, I'm here to introducing Dr. Francesco Paolo Muzio, which is talking about new therapies for heart failure with preserved ejection fraction. Just to quickly introduce you, Francesco. Francesco did a bachelor degree in biology in 2014, then he came to my lab at 2017, more or less. This was a period that the lab was under construction, actually. And he asked me to do the internship for thesis. And I said, okay, why not? And I immediately realized that Francesco has some sort of burning passion for the research. He started really to read a lot, learning a lot, doing experiments, really like an experienced researcher, but was not the case. And then he got the degree in biological science, and then I asked Francesco, what about doing a PhD? And he said, maybe, okay, let's start to build up your academic career. So he applied for a PhD courses in the University of Verona. At that time, we were collaborating with the cardiothoracic surgery department in University of Verona. So he got the first score, and he got the PhD. And during the period that he did a bit in Verona, but most of the part in my lab, he gained also the PhD with Dr. Europeus, because in the meantime, I said, Francesco, if you want to do this job, you have to go out. And during the PhD, he spent 4 months at the Charité University of Medicine in Berlin, where he learned a topic which was still in cardiovascular science, but something that we are not able to do in Italy, which is actually studying cardiac science in large animals. He did this, he came back, he got a PhD in Dr. Europeus, and what he lived in the Charité University was such a good impression that they asked him to do the postdoc. And I said, Francesco, it's the right time, right place, so you have to go there. And he spent a couple of years, a little bit more of 2 years at the Deutsche Herzzentrum, still at the Charité. He learned new things, many other skills. And then he applied for the Marie Curie MSCA action, got the Seal of Excellence, and then applied for the project of the Minister of University and Research in Italy, and he got this RTDA. Now, just to give you an idea about Francesco in number, because it looks like easy to talk about Francesco in this way. So during the PhD courses, he got the Best Poster Award International at the Mechanical Copy meeting in Freiburg. Then he was recognized at the Young Research Prize at the Italian Society of Cardiovascular Research 2022 during his first postdoc. Then he got other 2 or 3, but one of the most important is also a Travel and Grant Award for the European Society of Cardiology in heart failure, and this is the topic that we are hearing today in London. During the PhD, which lasts 3 years, he was able to take 11 peer-reviewed articles, all in Q1, 4 as a first author. Then during the postdoc, even more, so 15 articles still in Q1, and there was a first author in the 6th paper. But it was not enough. So in the meantime, he founded a startup, which is called GemTech, together with another student that I got in the lab. This GemTech is still present. It's a Parma startup. Francesco, he's an R&D chief, And they basically build up such a video cardiographer, which is a machine which is able to measure kinematics during heart surgery in clinics. The research interest, you already understood from Francesco, is cardiometabolic. Cardiometabolic pig model for heart failure, basically. But then he also developed skills in preclinical model of vascular injury for therapeutic development, and then he moved to clinical database analysis in heart failure, and then he got also expertise in cardiac electromechanical coupling, and together with the startup, video-based kinematic evaluation. Now, if we go throughout all of these points, we see that Francesco, despite his little age, is able to cover basic science, translational science, clinical science, and technology transfer, which is quite unique in the panorama of young researchers. Now, back to the topic. We're talking about heart failure. Heart failure is a condition where the heart is not capable or is little capable to pump the blood. We are talking about 15 million people that live with heart failure in Europe. The incidence is quite huge because we have 9 cases for 1,000 persons a year. We have a geographical variability across almost all countries, and the burden aspect is to increase with the aging population. Now, talking about healthcare burden in Europe, the median hospital stay for heart failure is 8.5 days per admission. We have a mortality about 8% in the hospital. It's a 1-year-old case mortality about 14.5%. And we have also frequent hospitalization this severity disease and also healthcare use. Heart failure still remain associated with high mortality and recurrent hospitalization after discharge. Now, talking about money, heart failure, it costs us 28 billion per year in Europe. It's still the first cause of death, is the first cause of hospitalization, and it takes all the coverage of cost in the hospital, about between 40 and 90%. And then there are other costs like medication, outpatient care, procedure, and so on. We have a primary care for heart failure, and also we have also the indirect cost for the heart failure. So impose a major economic burden driven largely by recurrent hospitalization and long-term care. Now, in the clinical setting, there are 2 types of heart failure. One is the classic one. The heart is not able to pump, and it's called heart failure with reduced ejection fraction. So the patient goes to the doctor, they do the ECG, first level, they do echocardiography, second level of diagnosis. In the echocardiography, they realize that the heart failure is less than 40%. So the ejection fraction is less than 40%. So this is a progression towards the heart failure. Moreover, the heart goes to some sort of eccentric remodeling and decrease the mass of left ventricle compared to other ratio. But there is another heart failure, which is called heart failure with preserved ejection fraction. Now, if we are going through the ECG, perfect. We are going through the echocardiography, perfect. Is ejection fraction preserved? Then it's more than 50%. But the heart starts to be stiff, so it's stiff, the heart muscles. We have a remodeling, a tissue remodeling, which is concentric, and the left ventricle mass increase compared to the volume ratio. But we are not able to detect this one of the problem. The fact is the mortality is the same. So the mortality of heart failure with preserved ejection fraction is comparable to what we observe with heart failure with reduced ejection fraction. So the trends of mortality is really similar. A few years ago, heart failure with preserved ejection fraction, which is called HFpEF, has been called some sort of diagnostic dysfunction. But now they realize that is not a disease related to diastolic, but is a disease related to certainly the heart. What about treatment? The first line of treatment of heart failure with preserved ejection fraction is SGLT2 inhibitors, like empagliflozin, dapagliflozin, and all these kind of drugs. But they are primarily hemodynamics tools. They are not directly target the heart. Reduce pressure, help the kidneys, but they are not really cure the heart. They do not stop the heart muscle from becoming more stiff and fibrotic. Very recently, there is another line, which is a second line, which is a GLP-1 receptor agonist, like Ozempic. We know all of them. All of us knows Ozempic, Trulicity, Mounjaro, Victoza. They are all GLP-1 receptor agonists, which start to be realized, and keep also this with the criticism mentality as a panacea for the heart failure with preserved ejection fraction. So in the heart, GLP-1 receptor agonists influence the heart rate, inflammation, reduce hypertrophy. In the lungs, reduce inflammation. In the pancreas, enhance insulin secretion. In the kidney, improves the renal blood flow. In the vasculature, supports vasodilatation. So, looks we are done. In the early phase of therapy, yes, so GLP-1 receptor agonists appear to extend predominant weight-independent effect, but as we have a rapid reduction in the blood pressure, aldosterone and angiotensin too. And these observations are consistent with modulation of sympathetic outflow, for example. But with the long-term treatment, weight loss, which was one of the main lateral effect of GLP-1 receptor agonists, and activation become increasingly difficult to disentangle. And GLP-1 receptor agonists may be better viewed as an amplifier, as acceleration and accelerator of beneficial hemodynamic, metabolic, and inflammatory consequence of weight reduction. But taking GLP-1 receptor agonists for heart failure with preserved ejection fraction, it looks like an elephant in the room. When medication stops, and you cannot take GLP-1 receptor agonists forever, the physiological drivers of HFF return with a vengeance. Within 6 months of stopping the drugs, the reduction in cardiovascular risk begin to fade. These are papers that came out a month ago on British Medical Journal. A patient who stayed the medication for 2 years saw a 22% of increase in the risk of heart attack, stroke, and death. Even if the patients restart the drug, they only partially regain the protection. And the interruption itself may cause lasting and metabolic scarring on the heart and the vessel. Now, the weight regain after stopping GLP-1 receptor agonist is faster than the weight regain after stopping traditional diet exercise programs. So, and about HFF implications, since it's often driven by epicardial fact, the return of this weight directly triggers the inflammation that define the disease. So, in terms, there are no definitive treatment yet existing for HFpEF. HFpEF remains an unmet therapeutic challenge. Current therapy improves really symptoms and reduces hospitalization, but their effect on mortality remain limited. HFpEF is still a heterogeneous systemic syndrome, unlikely to be addressed by a single treatment strategy, and the long-term access and affordability remain still a major barrier, particularly for newer metabolic therapies. For this reason, new therapeutic strategy for heart failure with preserved ejection fraction, which is the title of Francesco's talk, remain a major clinical and translational priority. I think I already talked enough. I leave the stage to Francesco, and thank you.
Can you hear me? Yes. Okay. So, I start my presentation actually with the letter that we received as a postdoctoral fellowship applicant to the Marie Curie. And this is the question that I actually asked myself the moment I received this letter. So basically you have to understand the context. There are a lot of emotions going on. I struggled a lot in writing this project. I had to study a lot. And then at the end of the day, you receive this definition by them, that it's a nice project, but no funding for you. So you ask yourself if it was really worth it. And I was finally able to find the answer to this question when I came back to Parma, actually, and after a period abroad. So I will also work later on, as Professor Miragoli basically introduced, with heart failure. So there was already failure inside my destiny. So basically, this is heart failure. Given that not everybody is in the cardiovascular field of research, I'm going to briefly describe it with more details. So here you have a healthy heart. So you have right and left ventricle, and you can see this parameter, the ejection fraction, which is basically the percentage of blood that is ejected by the left ventricle into the system. However, in this pathology called heart failure with reduced ejection fraction, you actually have this structural remodeling that Professor Miragoli was telling you. So you have an enlarged left ventricle with a very thin and weak heart muscles. And so what does it mean, basically? That the ejection fraction is reduced. There is an inability to pump efficiently the blood into the system. And these are the clinical symptoms of heart failure. They are also really common, but they can get really severe. So you have fatigue, you have lung congestion, so this liquid inside the lungs, exercise intolerance, because you also have basically skeletal muscle remodeling, edema in the feet and the legs, dyspnea, this shortness of breath, and this hunger for air, and that's basically all the symptoms, more or less. However, why I am citing them? Because we also have to be some kind of investigators into the history of heart failure. So already in 1933, basically this heart failure was only heart failure with reduced ejection fraction, which from now on I will call FF. And there was only the definition as basically inability to pump the blood into the system. So we only had heart failure with reduced ejection fraction. However, then there was evidence of patients actually having a normal ejection fraction, but with still some disease, some symptoms of the typical of heart failure. And so already in 1985, they started using this clinical term that is basically syndrome. And it's not only inability to pump blood, but it's actually also a structural remodeling of the heart with the increased filling pressure. And so only in 1995, we will have the first heart failure guidelines. So FPEF was discovered, and again, you can see an healthy heart, and here the HFpEF. So you have an increased left ventricle myocardium that actually reduced the chamber dimension of the left ventricle. And this actually is the motive why you have a preserved ejection fraction, because the ejection fraction is the amount of blood ejected by the left ventricle into the system. But you start with a reduced amount of blood, and that's the same amount of blood that goes into the ventricle. So they started giving a more broader definition of heart failure. They started using again this term of clinical syndrome, and only recently, so think about it, only recently in 2021, we actually have the heart failure classification and universal definition by the clinicians. And now it's actually defined as a structural remodeling of the heart with either inability to pump blood or stiff myocardium and diastolic dysfunction. So as Professor Miragoli already told you, we have basically these two of the most common phenotype, but there are way more. So the universal definition of heart failure actually says that you have to find structural remodeling, and how you do that? You use echocardiography, and you check for atrial remodeling and the left ventricle remodeling. You also check for this index of diastolic dysfunction, the E over E prime, to check if you have basically an impairment of diastolic function. But the definitive definition and diagnosis of heart failure with preserved ejection fraction is the invasive measurement that you can only perform with invasive catheterism of both right and left ventricle. And you can measure these two parameters, the precapillary wedge pressure and the left ventricle end diastolic pressure, which are actually the clinical threshold for definition of heart failure. However, you must also check for biomarkers, and this is the most common biomarker of heart failure. And of course, clinical signs. Typical, it's the dyspnea, because it says that you have lung congestion. So back to my topic now. The FPF was so much underdiagnosed in the past because it's really heterogeneous. And basically, as Professor Miragoli said, it's above 50% of all the cases of HF right now because it was so much underdiagnosed in the past. And you can see here in this picture that you have these three phenotypes, which are only some of them of the FPF phenotype. What they have in common is that you have this bidirectional crosstalk between metabolic stress and inflammation. And FPF is increasing in prevalence because of aging population, but especially in the Western society because of obesity, hypertension, metabolic syndrome with dyslipidemia, and type 2 diabetes. What I studied is actually cardiometabolic FPF. So really a brief introduction to make you understand that this is the situation. You have this so-called Western diet, specifically for our society, with metabolic stress and hypertension. And what happens is, okay, you have this structural remodeling that I told you before, but you also have deposition of epicardial adipose tissue. And this actually calls for cytokines, inflammation markers, macrophages, T cells that are activated into the myocardium. And this brings to more damage and oxidative stress. But it doesn't stop there. It's even more complicated because it's a syndrome, as I was telling you before. So it involves other organs as well. And one of them is actually, of course, the organelle of the mitochondria. So there is also mitochondrial dysfunction in this patient. And of course, also endothelial dysfunction, because the endothelium is also inflammation with the reactive oxygen species, as we are going to see later on during the presentation. So the other question that I had to actually answer when I went to Berlin, it was how to effectively model FPF in an animal, because I'm into the animal research field. So you have to respect these four pillars. You must have hypertension or cardiometabolic features. You must also show that you have preserved ejection fraction that does not deteriorate over the time. So because it becomes heart failure with reduced ejection fraction. And then in echocardiography, you must look for this cardiac remodeling with stiff myocardium and left ventricle concentric remodeling. And finally, the signs of FPF. So in the literature, we actually have two rodents models, and we are going to look at them very briefly towards the end of the presentation. This is the mouse model from Professor Schiattarella, another Italian that worked at Charité. And it's a high-fat diet, so that Western diet, high in fat, salt, fructose, and this L-name, which is a compound that basically induces hypertension. And then this other model that we talk later, the ZS1 rat. However, the other two, the most clinically relevant ones, are actually the pigs. So you again have this big pig, which is the Ossabao pig, and you use a high-fat diet and aortic bending to increase the pressure into the system. However, this model, it's good for sure, but as you can imagine, it's really big. The animal gets even bigger, and it's really difficult to handle. So for this reason, the actual model, that it's the most clinically relevant one, it's the Göttingen mini pig. This model was developed by Sharp III et al. In 2021, and as the graphical abstract suggests, you can see the multi-comorbidity and multi-organ involvement. So you have the heart that is involved, the lungs, the kidney, the pancreas, and of course, the endothelial dysfunction. So all the features that I told about before. And how you do that? You use this high-fat diet, as I told you, but also this other component, DOCA, which is an analog of the aldosterone and actually increases the hypertension, the blood pressure, and induces hypertension over 20 weeks, so over 5 months. However, for as much as a good paper this was, there are different limitations. They only performed 3 control versus 5 FPF. They also did not perform some measurements over the whole 5 months, and they did not perform invasive hemodynamic assessment together with, of course, molecular profiling. So now I move to Berlin time, to my period. I work with the supervisor, Alessio Logna, and the veterinarian doctor of the lab, Jens Otvosch. Of course, the team was enlarged. It got bigger over time. Most of them are my students and still are. And together we worked for this project. This is basically the study design that I refined personally, together, of course, also with Alessio. And as it can be noted, it's a 3-arm study design with a repeated measure over time, over the 5 months period that Sharp et al. Basically described. And you can notice that I placed different measurements all over the 5 months, because I want to check all the measurements that are clinically relevant for the phenotype. And specifically, the orange data point, time point, as you can see, they have this the administration of anti-MIR, something that we are going to talk later, but also invasive pressure in the right ventricle, which was something that was missing in Sharp et al. And finally, at the end point, I actually performed invasive hemodynamics measurements to finally characterize the model. So I'm going to briefly overview the data that I was able to collect during my time. The study is still going on, so we actually aim for 11 animals per group. And I was, because it's a long experiment, 5 months, I was only able to do 5 and 5 at the time. So you can notice that we have for sure obesity, because the body weight of the animal is steeper, the increase compared to the control. But of course, we cannot stop there. We have to check also for the dyslipidemia factor. And how you do that? Oops. You do that thanks to basically the checking in the blood, a basic cell count, and lipids count, and lipoprotein counts. And what you can notice is that basically over time, over the whole period of 5 months, you have this increase of all levels of the lipids and also the lipoproteins. And so we can for sure say that we achieved metabolic dysfunction. Of course, we have to check for the invasive pressure, for the hypertension, and for that you measure the non-invasive blood pressure with the tail cuff, and you can notice that we have an increase of systolic blood pressure, diastolic blood pressure, and also mean aortic pressures. So for sure we have the risk factor of hypertension. Just to mention that these animals are actually under anesthesia during these time points. So the effect that you're seeing here is actually higher, because under anesthesia you reduce a little bit more the blood pressure. And then of course you have to use echocardiography for the evidence of structural remodeling. And the first parameter must be the ejection fraction. And here I highlighted for you the clinical threshold and range of ejection fraction, and you can see that both control and FPEF group are within this range. But you don't stop there, because you must check for structural remodeling. And how you do that? You measure the left ventricle wall thickness, which you can see it's increased already and established this hypertrophy from week 12 to week 20. Then also you measure the left ventricle mass, which highlights basically that the whole left ventricle is increased compared to the whole volume of the heart. And finally, this parameter, which is a composite parameter of echo, the relative wall thickness, which includes the left ventricle thickness, but also the internal diameter of the ventricle and the septum. So it's a more complete estimation of the cardiac remodeling. And you can see that it's increased already from almost week 8, but definitely in week 12 going onwards. So for sure we have what is specific of FPEF, which is the concentric remodeling. Finally, as I told you, it's important that the invasive assessment must be performed to measure the pressure inside the right ventricle. This catheter is called Swan-Ganz, and you enter from the superior vena cava into the right atrium, then the right ventricle, and you go farther into the main pulmonary artery, and then farther even more to measure the precapillary wedge pressure, which has a clinical threshold for FPEF. So you use, we measured all these parameters, and you can see the threshold was 15 millimeters of mercury, and it's already exceeded at week 12. and even farther in week 20. So for sure we can say that our model has increased filling pressure. Then of course we also measure the pulmonary arterial pressure and very interestingly also the right ventricular pressure. So as much as the increased pulmonary arterial pressure is important in the FPEF, because it means that the right ventricle has increased pressure and it's working with more stress and more force, this is actually the most important parameter, because these patients, it's a common sequelae to also develop another pathology, which is the pulmonary hypertension group 2, which basically from the left side pathology, it comes back to now the right side of the heart, so back to the right ventricle. So possibly, even farther, if we kept going with the protocol, possibly we might develop also pulmonary hypertension in this model. And, oopsie. To conclude, this data that I acquired, we also performed the left ventricular catheterization. And these are these beautiful graphs called PV loops that basically it's the pressure volume works inside the heart, inside the left ventricle specifically. And you can notice how big is the PV loop of the FPEF compared to the control. And what does it mean? The area inside these loops, basically, it's in physical terms, corresponds to the energy consumed, to the fatigue that the heart is basically doing. And this parameter is actually the stroke work, and you can notice that it's definitively increased in the FPEF. Then I also highlighted for you some interesting point on the graph. Of course, the hemodynamic assessment has more than 20 parameters, and I cannot show you all of them, so only the most important one. You have an increased end-systolic pressure. Of course, also, this other pressure is important, the end-diastolic, which also has the clinical threshold of 15 millimeter of mercury, which we for sure exceeded. And also we found an increased end-diastolic volume, because now in the late stage of the disease, some blood remains inside the ventricle. So now I'm going to talk a bit about the other arm that I was referring to before, this anti-MIR arm of the project. And it comes from working with this other professor, Nicole Krenkel. Nicole Krenkel studied this microRNA for A33P, and she found it increased, overexpressed in humans patient with type 2 diabetes, and also in a murine model of type 2 diabetes. And so she started thinking that from this analysis, that the endothelial dysfunction is linked to this overexpression of this microRNA. So she performed an in vivo study on a type 2 diabetic model of a mouse, and she performed this injection with a scramble in the same model, and with this anti-microRNA specifically. And what you can notice that the model that is treated with the anti-microRNA is to the same level of re-endothelialization, which is basically a parameter of vascular function, to the same level of the control, while the other model is definitely decreased. And actually she checked for the expression of this microRNA and found it way more increased in the untreated one compared to the treated one, that it's again to the same level of the control. So why I'm citing this? Not only because they are performing this study in Berlin up to this day, but also because I was able to formulate my own idea, my own hypothesis. And this hypothesis that I started studying all this microRNA involved in heart failure with preserved ejection fraction, and I found a specific one, a very promising one, that can be possibly used for the therapy. However, to deliver the therapy to the heart, you must protect this microRNA for the endonuclease inside the blood, and for this reason, I thought of the calcium phosphate nanoparticle to protect this microRNA. And to give even more specificity in the therapy, I want to functionalize this calcium phosphate nanoparticle with the cardiac-specific aptamer, so to increase basically the specificity. This idea has been recently submitted. Then I came back to Parma in the TechMed lab with Professor Michele Miragoli and the other colleagues that are present here. And I want to study another promising pathway involved in FPEF, which is the inducible nitric oxide synthase, which I will call for simplicity NOS, which is involved in FPEF Of course, by itself, this pathway is involved in different pathologies, not only in FPAF. So it's in pulmonary hypertension, it's in chronic inflammation, also stuff, basically conditions that you have in FPAF, of course. But in FPAF specifically, it induces this accumulation of S-nitrosylated protein into the cardiomyocytes, mitochondrial, and endothelium. And now we go back to this model of the mouse with Professor Gabriele Schiattarella that actually developed not only the model that you can see as all the features specific of the HFpEF, so a preserved ejection fraction, an increased in the diastolic dysfunction parameter, and also congestion in the lungs with, of course, cardiac remodeling, as you can see. And he actually checked for the expression of the mRNA of this INOS, and he found it overexpressed in the model. So he started looking at my same idea, as you're going to see, trying to inhibit this INOS. And he used a specific inhibitor, which is the L-NIL, which, however, is a broader inhibitor of the whole pathway of the N-nitric oxide synthase. So we have 3 isoforms for those that are not common with this pathway. We have the endothelial, the neuronal, and the inducible one. So he found that basically the main parameters of systolic blood pressure, diastolic blood pressure, and the diastolic dysfunction are changed differently. As the blood pressure does not change, what he found was that the E over E prime, so this diastolic function parameter, is reduced after therapy. However, during my studies, I'm actually starting to be skeptical about this model, and for this reason, I actually came up with another idea on another model, which is the ZS1 obese rat. This rat allows us to use more clinically relevant methods for measuring the clinical parameters relevant for HFpEF. And I want to use also another inhibitor, which is more specific compared to the L-NIL that Professor Schiattarella used, which is the 1400W. And so this is something that I already submitted, and I was supported by Azione B from the University of Parma. And you can notice this pathway. Basically, I am using the same concept that I developed during this year abroad. And I used the 3-arm design with an internal control that the ZS1 model has, and a treatment group and a controlling group. All the measurements here are all relevant for the FPEF phenotype, and of course, in the hand data point, I will perform invasive hemodynamics measurement to functionally characterize the whole model. So we are at the end of the presentation, and so finally I can answer this question freely. I worked in a really interesting field of research, which was different from what I was used to work when I was in Parma. So this learning skill was really important because I had to learn how to handle the big animals. I had to learn how to do echocardiography in the animals and also invasive hemodynamic measurements. I created an international network that up to this day I still collaborate with, and I came up with personal ideas and hypotheses as I showed you. So was it worth it? I think yes. Thank you all. If you have any question, I'm...
My question is also because I'm sorry, for the back, not saying. One short. Yes, one short because we're running out of time. But sure. Based on what I see there, like, you know, your volunteers, yes. Is this whole thing easily translatable to humans? I mean, what's the distance? What are the steps in between this and the applicability to humans?
So for the applicability in the humans, of course, first of all, we have to finish this project that now the students are completing. Actually, the 2 students that are here in the cage, yeah, we have to check that this anti-microRNA therapy is actually reducing what we hypothesized is blood pressure, this blood pressure increase, the hypertension, and also improving the endothelial function. And then from that, we are obliged by European law actually to perform again the model, but this time using a scramble with the control. So basically the same structure of the microRNA, but with no effect. And after that, then possibly you can apply for humans.
Okay. Thank you, Francesco. Really nice presentation. One question is about the anti-microRNA. How is cardiac specific? Because I remember at the beginning of the microRNA story, the microRNA that was upregulated in hypertrophy, they tried to also make some trials, but they upregulate everything in the organ and not only in the heart. So how real is the specificity of this anti-microRNA for the heart?
That's a very good question, and actually it's the problem with any therapies with the microRNAs. The microRNAs have a different off-targets effect. So even if they can be maybe cardiac specific, they actually will be involved in other pathways in other organs. And actually this microRNA that Professor Krankel studied is actually upregulated not only in the heart and endothelia, but also now we have seen with some preliminary data that I was not able to show in the liver. And we actually are seeing something really strange, like a decrease of the lipids, which we don't know still now why. So just to answer the question, pleiotropic effect for sure.
Yeah.
Francesco, nice talk.
Thank you
I
so
have
much.
more of a general questions coming from a non-expert. How good it is an animal model when considering that in humans, obesity and type 2 diabetes are comorbidities in people who have heart failures?
So it's my personal idea, of course, so I'm a little bit biased, but it's really clinically relevant because in the patients you have a bigger problem. You have too many confounders when you perform any clinical studies. And it's very difficult to account for all these confounders. While with this model, you actually have a more controlled environment where you can mimic basically specific comorbidity involved, because as I told you, there are different phenotypes, and this is only one phenotype of FF, the cardiometabolic one. And so it's, in my opinion, again, it's very clinically relevant.
Thank you.
Any other questions? Yes.
I had a question also about the animal model, and I was curious if there was any control or concern for the genetics and how they were selected. With, I understood there's just 10 pigs that you've done so far, and I also had a question, did you also run it with the 2 mice and the other pig, or just the last pig model?
Myself?
Yeah.
Myself, only the large animals. So I worked only with the pig model. And you asked me something about if I understood the genetic background, right? So this model actually, it's a specific model that is not available in nature. This was created in a lab. It's, the company is called Ellegard in Denmark, and they created this Göttingen mini pig by breeding specific genetic and having a structured genetic background. They are actually prone, like humans, to be obese. So it's actually, back to the point of the other question, really clinically relevant as a model. Thank you all for your time.
And